It's time for another 3-question warm-up. Let's get going. A woman commonly develops intense muscle cramps and darkening of her urine after exercise. What is her diagnosis? So this is classic for McArdle disease. Next question. What personality disorder fits each of the following statements? So first we have sense of emptiness and loneliness and impulsiveness. This is characteristic of borderline personality disorder. Odd appearance, thoughts, and behavior. No psychosis though, and social awkwardness, that's going to be schizotypal. Controlling, perfectionistic, orderly, stubborn, indecisive, that's going to be obsessive compulsive. And then criminality, unable to conform to social norms, disregard for the rights of others, that's going to be antisocial. Next question. What substances are well known for causing hemolytic anemia in patients with G6PD deficiency? So there's a good mnemonic. Spleen purges nasty inclusions from damaged cells. Kind of a long one there. So S is for sulfonamides, which we've seen before. P is for primaquine, which is an anti-malarial drug. N is for the antibiotic nitrofurantoin, which is really rarely used for anything but UTIs. I is for the antibiotic isoniazid, or also referred to as INH, that's used for the treatment of TB. F is for fava beans, which is really the only one on this list that isn't a drug, but it's still a pretty classic one worth knowing for your test. D is for dapsone, an antibiotic which is used mainly for leprosy, sometimes for PCP prophylaxis. And then the C is for chloroquine, which is another anti-malarial drug. That's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about platelets. But first, I need to get my head right. Woo! Let's talk about how platelets work. Then we'll review some drugs that affect platelet function. Platelets are an important part of the body's response to vascular injury and an important part of hemostasis. But again, we're deliberately talking about platelets separate from the coagulation factors so they don't get too jumbled up in your mind. First of all, platelets come from precursor cells called megakaryocytes. Remember, megakaryocytes are huge. They're megakaryocytes. And they pinch off little bits of cytoplasm and cell membrane, which are the platelets. Now, platelets have no nucleus, and they only live 8 to 10 days. It's tempting to think of platelets as little inert fragments that don't really do much but plug up holes in blood vessels. But in reality, they're a lot more complex than that. They have several different kinds of glycoprotein receptors, and they contain granules filled with various signaling substances. There's actually a lot going on with platelets, especially when you consider that they're so tiny, and they have no nucleus, and they can't make any proteins. So let's talk about how platelets work and how they stop bleeding. Back when we talked about coagulation, I mentioned the fibrin clot, or the fibrin mesh, that's the end product of the coagulation cascade. That fibrin clot is the more permanent blood clot, but that takes a little time to form. So the very first step in hemostasis is formation of a platelet plug. So first you plug up the hole with platelets, and then the second step is to activate the coagulation cascade and form the fibrin mesh clot. But the platelet plug comes first. Now, the phrase platelet plug can help you remember that the platelets act first, because when you spring a leak, the first thing you need to do is plug that hole. If you're in a rowboat and it springs a leak, the first thing you want to do is plug the hole quickly, and then you can figure out a way to patch the hole. So the platelet plug is the first step to plug up the hole, and then the fibrin mesh is the permanent patch. So when you have an injury to a blood vessel, that leads to platelet adhesion, then platelet activation, and then finally platelet aggregation. These are important steps: adhesion, activation, and aggregation. First, the platelets have to adhere to the injured surface, then they have to become activated, and then they aggregate and clump together to form that temporary platelet plug. And it's important to understand each of these steps, so we're going to talk about each step in detail. Let's talk about platelet stimulation. First of all, lining the blood vessels is the vascular endothelium. And what's inside those endothelial cells? Well, there's von Willebrand factor, and there's thromboplastin, also called tissue factor, and there's TPA, which is tissue plasminogen activator, and there's PGI2. But for now, let's focus on von Willebrand factor. Take a look in your study guide. Von Willebrand factor is made up of several subunits that are linked by disulfide bonds, and it's synthesized by endothelial cells and megakaryocytes. Now, we just talked about how megakaryocytes are what make platelets. So platelets also have von Willebrand factor inside them, as we're going to see shortly. Then von Willebrand factor has two major functions. First of all, it complexes with factor VIII and stabilizes it. So a deficiency of von Willebrand factor, which we call von Willebrand disease, will look a lot like a factor VIII deficiency, which can lead to elevated PTT. And what disease results from factor VIII deficiency? I'll give you a hint. Remember that 8 sounds like A? It's hemophilia A. So just like hemophilia A raises your PTT, so can von Willebrand disease. And the other major function of von Willebrand factor is that it's involved in platelet adhesion to the vessel wall and also adhesion to other platelets. This means that deficiency in von Willebrand factor will also lead to an increase in bleeding time. Remember, bleeding time is a measure of platelet function, where you cut the skin and you see how long it takes for the bleeding to stop. Now, since the platelet plug is what stops the bleeding initially, the bleeding time is a test of platelet function. So bleeding time will be prolonged in anything that impairs platelet function. So von Willebrand factor is important for both the coagulation cascade and also for platelet adhesion. And if there's a von Willebrand factor deficiency, the platelets can't adhere to the injured endothelium, they can't form that platelet plug, so bleeding time will be prolonged. Going back to our blood vessel, the thing that kicks off thrombogenesis is some kind of injury to the vascular endothelial cells. Now, when the endothelium is injured, the subendothelial collagen is exposed, and you have some platelets just kind of floating by. Now, when the endothelium was injured, von Willebrand factor and all those other chemicals leaked out of those damaged, ruptured endothelial cells. But we're still focusing on the von Willebrand factor for now. Von Willebrand factor is going to bind to that subendothelial collagen. Then it's also going to bind to a glycoprotein receptor called glycoprotein 1b, which is found on the surface of the platelet. That's how platelets begin to adhere to the damaged endothelium. So the injury leads to platelet adhesion. The next step after platelet adhesion was platelet activation. And that basically means that the platelets change shape and they grow these long fingers or pseudopods that help them bind tightly to the injury site. And then the activated platelets begin secreting lots of important substances. So we talked about all the stuff that was found inside endothelial cells, but there's lots of stuff inside your platelets too. Remember, platelets don't have nuclei or a lot of cellular machinery, so they can't make anything, but they come preloaded with several important chemicals. They have von Willebrand factor again, and also some fibrinogen, cyclooxygenase, thromboxane A2, and a lot of other chemicals. These are actually outlined in the study guide under platelet stimulation. The first bullet is adhesion, which is the first step of platelet stimulation. We just covered that. Then the second bullet is activation. So activated platelets secrete a bunch of stuff. They secrete ADP, platelet-derived growth factor, serotonin, fibrinogen, lysosomal enzymes, thromboxane A2, which, as you remember, is a prothrombotic substance that's going to induce thrombosis. It's right there in the name, thromboxane. Platelets also secrete calcium, which is needed to activate the coagulation cascade. Several steps in the coagulation cascade require calcium. And the platelets also secrete thrombin. And remember that thrombin converts fibrinogen to fibrin, and fibrin is what forms the fibrin mesh clot. And when the platelets release thromboxane A2, that leads to vasoconstriction and platelet aggregation. So thromboxane A2 comes from platelets, and it also induces further platelet aggregation. So besides forming the platelet plug, activated platelets also release a lot of things that are necessary components of the coagulation cascade, like fibrinogen and thrombin and calcium. So we had adhesion of platelets, then activation of platelets. Now we're ready to talk about aggregation of platelets. Again, one of the things that the activated platelets secrete is ADP, adenosine diphosphate. And on the surface of the platelets, there's an ADP receptor. And when ADP binds to that receptor, it triggers the expression of a glycoprotein 2b3a to come from inside the platelet to outside the platelet. The ADP receptors basically tell the platelets to start putting glycoprotein 2b3a on the surface of the platelets. Now, 2b3a is very important in allowing platelets to aggregate because the 2b3a on the surface of the platelets is going to bind to the fibrinogen that the platelets released. That's going to form a series of cross-links between platelets. So this is platelet aggregation. The platelets start to aggregate and they form a plug to temporarily stop the bleeding. So the activated platelet basically releases everything it needs to promote platelet aggregation. So that's how platelets work. And understanding these steps will help you understand the mechanisms of various antiplatelet drugs, which inhibit platelets at different steps in this process. Let's talk about antiplatelet drugs, starting with aspirin. Aspirin is a type of NSAID, so it inhibits cyclooxygenase. Aspirin acetylates both COX-1 and COX-2, so it permanently inhibits them. And that blocks the conversion of arachidonic acid to thromboxane A2. Now we said that thromboxane A2 will stimulate platelet aggregation. It's thromboxane. It stimulates thrombosis. So if you inhibit thromboxane synthesis, you're going to inhibit platelet aggregation. Now, since aspirin affects platelet function, a patient on aspirin will have a prolonged bleeding time, but PT and PTT are not affected. Lock that in. Bleeding time measures platelet function. Now, aspirin is used for a lot of different indications. It's used to reduce fever, to treat pain, it's used as an anti-inflammatory, and as an antiplatelet drug. So we give aspirin to patients with an acute MI or acute coronary syndromes to block platelet aggregation and thrombosis of the coronaries, right? Or in an acute stroke. And we give a low dose of aspirin daily to prevent MI. You also need to be familiar with the side effects of aspirin. Obviously, any drug that inhibits platelets can lead to some bleeding. Inhibition of COX-1 in the GI tract can also increase the risk of peptic ulcers because you're not going to have the protective prostaglandins in the stomach. And you can possibly have some hyperventilation because aspirin directly stimulates the respiratory centers of the brain. So you hyperventilate and you get a little respiratory alkalosis. And we mentioned that when we discussed acid-base disorders in the renal section. But we also said that since aspirin is an acid, eventually that respiratory alkalosis might transition into a high anion gap metabolic acidosis. Now, aspirin poisoning and salicylate toxicity can be associated with tinnitus or ringing in the ears. And there's also a side effect called Reye syndrome, which is why we generally don't give aspirin to children. Reye syndrome is a type of hepatoencephalopathy. If you remember that name, hepatoencephalopathy, it's going to help you remember the features of Reye syndrome, liver problems and encephalopathy, and also hypoglycemia. Now, what's the one pediatric disease where we do give aspirin? I'll give you a hint. Coronary aneurysms and desquamation of the hands and feet. It's Kawasaki disease. That's one of the few times we do give children aspirin. Another class of antiplatelet drugs are the ADP receptor inhibitors, or ADP blockers, which include clopidogrel, which is the main one. Then there's also ticlopidine and a couple of newer ones like ticagrelor and prasugrel. Again, these are ADP receptor blockers, so think back to what the platelet ADP receptor does. When ADP binds to the ADP receptor, that induces expression of glycoprotein 2B3A on the surface of the platelets. So if you block that ADP receptor with one of these drugs, you're going to be blocking platelet aggregation. Now, clopidogrel is commonly given during an acute MI, or it can be given for 6 to 12 months following a coronary angioplasty with stenting. It's also used to prevent recurrent strokes. Or if a patient needs to be on aspirin but he has an aspirin allergy, you could use clopidogrel instead. And then the last category of drugs that affect the platelets are the glycoprotein 2B3A inhibitors. There's abciximab, which ends in mab, so that tells you it's a monoclonal antibody. Then the other 2B3A inhibitors are not monoclonal antibodies. These are tirofiban and eptifibatide. Now, all these block glycoprotein 2B3A, which was the surface molecule that binds to fibrinogen to cross-link the aggregating platelets. And make note that tirofiban and eptifibatide both contain FIB in the middle of the name, and that reminds us of fibrinogen. So the end result of blocking 2B3A with these drugs is that you inhibit platelet aggregation, similar to the way clopidogrel works. But these actually act on a totally different receptor and at a different step in the process. 2B3A inhibitors are mainly used for acute coronary syndromes, specifically the non-ST segment elevation MI. So for an ST elevation MI, you might give a thrombolytic like TPA or streptokinase. But for a non-ST elevation MI, you consider a 2B3A inhibitor. They're also used during and after angioplasty. Now we're ready for the end of session quiz. So pause the video, go through those questions, then we'll work through the answers together. First question, what's the lifespan of a platelet, which is also the maximum life of platelets after transfusion? It's 8 to 10 days. Next, what molecule is expressed on the surface of a platelet after it becomes activated? It's glycoprotein 2B3A. Next, NSAIDs inhibit the production of which substance important in platelet aggregation? Thromboxane A2. And the last one, what's the mechanism of action of each of the following drugs? So we've mixed all the antiplatelet drugs and the anticoagulant drugs together in this question for review. Streptokinase is a thrombolytic, which converts plasminogen to plasmin, which cleaves fibrin and breaks down clots. It lyses clots. It's a thrombolytic. Aspirin irreversibly inhibits COX-1. Clopidogrel blocks platelet ADP receptors. Abciximab is that monoclonal antibody that binds to glycoprotein 2B3A on platelets. Tirofiban also inhibits glycoprotein 2B3A. Ticlopidine blocks ADP receptors, just like clopidogrel. Enoxaparin is a low molecular weight heparin, which works by inhibiting factor 10A. And eptifibatide is a glycoprotein 2B3A inhibitor, just like abciximab and tirofiban. That's it for now. I'll see you next time.